Welcome, everyone, and thank you for joining us for today's HIMSS Industry Solutions webinar, Leveraging Data to Build a Post-Acute Formula for Success. It is being sponsored by Microsoft. I'm Gus Vendetto, and I am the moderator today. And I do want to encourage you to ask your questions during the presentation. You'll see the question icon on your screen. You can enter your questions there. And after the presentation, we will make every effort to answer your questions. How much do you know about your post-acute provider network? In today's value-based environments, it is critical to understand the 42% of Medicare beneficiaries who are receiving post-acute care. In today's webinar, you'll learn how to use analytics to develop a successful strategy for managing your post-acute care patients. Our speakers today are Donna Antonucci, Richard Juk-Devorian, and Todd Warden. Donna is the Chief Operating Officer and Vice President at Lourdes Health System. Richard is the Senior Vice President, Performance Management at PointRight, and Todd is the Chief Medical Information Officer and Medical Director at Lourdes Health System. With that, I'd like to turn it over to Donna to begin today's presentation.
Sure. Actually, I'm going to go ahead and bring us back for a second, and I'd just like to introduce Richard Juk-Devorian. Richard's actually going to kick us off. Apologies for that. Richard, if you could go ahead and get us started.
Absolutely. Good afternoon, everybody. This is Richard speaking, and I'm just going to talk for a couple of moments before allowing Dr. Warden and Donna to tell their story over at Lourdes a little bit about PointRight. PointRight has been around for the past 20 years, really focused on bringing analytics and robust data services to the post-acute care space. We have been collecting MDS records, which for those of you who are in the post-acute care space know that as the minimum data set. We have been collecting MDSs for the past 20 years and have amassed a database of about 45 million identifiable MDS records. We're proud to have 2 National Quality Forum endorsed rehospitalization metrics, both for a 30-day rehospitalization as well as for long-stay rehospitalization. And we actively monitor and measure about the entire skilled nursing facility landscape, about 15,000 nursing homes, and about 2,000 of which are currently PointRight customers utilizing our skilled services. In addition to that, there are about 200 acute care providers that utilize PointRight for the purposes of network build and network management, which Dr. Warden and Donna will go into a little bit more. And then a couple of years ago, we made a concerted effort to expand outside of our core post-acute care provider space and have started to work more closely with managed care organizations, accountable care organizations, and hospitals. This slide is going to take a minute to animate, so while it's doing that, I'll just talk a little bit about, I think most folks on the call are probably very well versed with the trends that are impacting post-acute care, to say the least of which are all of the payment reforms that have been taking place as part of post-acute care. First, starting in the acute care space with some of the Accountable Care Acts, but with Impact Act and others that are specifically focused on the post-acute care space, this is an area that is really getting a high degree of interest, a bright light, if you will, being shown upon the space of post-acute care. We see significant trends in managing that. So with that, I will hand it over to Donna to talk a little bit about the work that they've been doing at Lourdes. So Donna?
Yes, thank you. So as I was saying, good afternoon, everyone. Dr. Warden and I are really excited to share our journey at Lourdes. So I'm going to start by telling you a little bit about Trinity Health as a whole, and then Lourdes System, and how we're managing within our accountable care organization. So to begin, LHS Health Network is a part of Trinity Health, and Trinity Health is the second largest Catholic health institution in the United States. So Trinity Health is made up of 3 insurance plans, 27 ACOs at this point across 21 regional health ministries. We have over 10,000 physicians and advanced practice nurses that are committed to approximately 16 clinically integrated networks. We actually have more than 30 now regional health ministries within bundled payment programs. So you can see we've gone from actually 6 to 30 in the last few months. We have 27 regional health ministries with 65 patient-centered medical homes. And altogether at this point, we're managing about 1.3 million lives. I'd also like to tell you a little bit about LHS Health Network specifically. So LHS Health Network is a part of Our Lady of Lourdes Health System in Camden, New Jersey. We are an organization that is currently a PHO, a Medicare ACO, and also we're currently pending to be an organized delivery system in our state. We have about 85,000 total attributed lives in our programs at this point, and we're managing both on the managed care side as well as Medicare. Within the Medicare programs, we're linked to about 24,000 lives, and we're one of very few ACOs across the country that are involved in the next generation ACO. We are approved as a part of that ACO within Trinity Health, meaning that there are actually 5 regional health ministries within Trinity that make up our next generation ACO with Medicare. So specifically, LHS Health Network is a for-profit organization. It's managed by a board of managers, and it's primarily physician managers. Actually, more than 70% of our board is made up of physicians. We meet the requirements as a Medicare ACO, and as I mentioned, we are eligible and currently pending an organized delivery system certification in the state. And what we're trying to do now is really move towards fully capitated arrangements. Within our ACO, we have over 180 primary care physicians, and a part of that makeup is 2 very large organizations. One is Rowan Medicine, and the other is the Princeton Physician Network. There's approximately 45 practices in the ACO as well. We span through several counties in southern New Jersey, so we are in Burlington, Camden, Gloucester, and then also a bit more north in Mercer County. I think it's important to note that 1/3 of our network PCPs are actually employed, and therefore 2/3 are independent physicians. When we began the Medicare Shared Savings Program in 2014, we realized right out of the gate that our annual per beneficiary SNF costs and our network exceeded the national average by over 25%. So we recognized an issue right away. And what you can see there for the 4 quarters of 2014 is that our post-acute costs were exceedingly higher than other MSSP ACOs and also higher than the national average. So by Q4 of 2014, we were at $1,102 per beneficiary per year. Another issue that we found immediately is that our beneficiaries were using over 200 different skilled nursing facilities, which made it very difficult to really manage that care and control costs. And the last thing that we knew right away is that we hadn't shared our business model with the post-acute providers and knew that that's a road that we needed to go down. As we started to explore our journey and how we could get to the point of working collaboratively with our community providers, we decided to establish a post-acute committee to share information and to provide two-way education. So in September of 2014, we basically brought over 20 nursing homes together to talk about what we wanted to do or accomplish in the ACO, and then really to understand their business as well. We knew that some of the things that we wanted to attain as far as goals were concerned was to lower readmissions from post-acute care, lower the length of stay, or at least have an appropriate length of stay per condition, definitely improve the patient's condition on discharge from the post-acute setting, have really strong transitions of care, and then to avoid any adverse outcomes. So we really had an eye on quality as well. Our first step in this process, or this phase 1 of the initiative, was to create a scorecard or report card that would reflect the highest performing SNFs, and we refer to them as preferred providers. And what we looked at in that scorecard is the average length of stay as a performance metric, the 90-day readmission rate, and then we looked at Medicare's 5-star rating as well for nursing homes. Our next step then, after development of the scorecard, was to actually share that with the SNFs, or skilled nursing facilities, and have them see, one, what our expectations were, but also what their peers looked like on that scorecard. From there, once we developed the scorecard and had our higher performing providers, we actually placed a star next to their name and placed that on the bedside list that goes to patients when selecting a nursing home. We really found that this was the first time that patients could actually see some information. And you know, a lot of times with social workers working with patients on post-acute care, they're asked where they might send their patients, where they might send their own family members. And we never really had anything to share with patients of any substance when it came to performance. And so this scorecard helped us to do that. The scorecard itself was updated quarterly. Now I'm going to turn it over to Dr. Worden, and he's going to continue the journey for you.
Thank you very much, Donna. As Donna had mentioned, she initiated the Post-Acute Committee, and I think the success we had was in part due to the transparency of our process. Along this process, we explained every step of the way what we were doing and why. We worked closely with several of the SNFs to verify and authenticate our claims data. We actually sat down and compared our data in our claims to the payer submissions and payments. We did this for Medicare, Horizon, and Aetna, and when the data claims tied out to their submissions and payments, we really obtained their confidence in the SNF report card. And I don't think at this point we've ever really been second-guessed about the content of the report. So this is the data we focused on from the claims. And as Donna had mentioned, we selected average length of stay and 90-day readmit as proxies for utilization and cost. And we also felt these were more actionable items as opposed to really working with the SNFs with costs. And as you can see in the second column, we were looking at the number of SNF admits. In the fifth column, where it says paid amount per SNF admit, we could actually find out what was the actual cost of each individual encounter, and then the average length of stay is 2 columns over. And in our current report card, we also look at 30-day readmits, which is the next column, and then the last column, which is the readmit percent at 90 days. Now, from the perspective of weighting it and using it in our report card, we're really just looking at average length of stay and the 90-day readmit, and I'll show you a little more detail on that on the next slide, or in coming slides. Next slide, Petra, please. So our dilemma was we had this great claims data, but we really had no quality data, and we needed actionable quality data that looked at SNF staffing, leadership, and clinical coverage. And we also felt like we needed process expertise, compliance, and allegations on poor care. And ultimately, we selected PointRight because, one, they were the largest analytics skilled nursing company out there for SNFs. And they also incorporated patient-level data, the MDS data, as Richard mentioned, and they linked that to public domain facility-level data like state survey, which was very, very helpful. And this data that we get goes well beyond the CMS Nursing Compare, and we thought the PointRight data accurately represented indicators of SNF capability in areas that they could impact and improve care. You can go to the next, please. So this is really what one of the components of the report card and what it looks like. Now, there's actually 2 components to the PointRight data, and it comes in 2 separate formats. One's a large spreadsheet that has 1 row for each SNF and all the scores from all of this publicly accessible data that they gather. And we use that because it comes in an Excel spreadsheet, we actually use that to link to our claims file. But this is called the detail scorecard, and this is what we use to actually go to the SNFs, to report on what we think is actionable information. Now, when you look at it, the top part is mostly demographics. The next three areas down are actually reflective of one of 6 domains. But this is predictive information on readmission data that they present, and we decided not to use that because we really wanted to use our claims data because we had readmission information in there. So we focused on the box second from the bottom and the bottom box where they have the remainder of their 5 domains, which we'll go into a little more detail, but also their CMS 5-star score. And then on the right-hand side is really the breakout of the other 5 domains. You can go to the next slide, please. So just to dig in a little bit more, here are the 5 domains that we used in our SNF report card, including the CMS star rating, which they provide. And these are so you can go to the next slide, please. So I wanted to dig in a little bit more into the staffing and show you, the benchmarks that they use. So on the left-hand side, it's broken into, the different components, but across the top, the first column is going to be the measures of the particular SNF, and the next one is really your regional area within the state averages, and the national averages. So you have some really good information to compare to, your SNF's performance. Of the staffing components, the ones that I'm most interested in, when we're sitting down and talking to a particular skilled nursing facility, is the RN to total license ratio, which is an indicator of a high level of RNs, registered nurses. The indirect care percentage, which is what's the percentage of nursing time that's allocated to management and education of the staff, so it's not non-bedside time. So the higher the better, and PointRight likes to see over 10. I like to see more like 14 or 15, and you can see here the state average is 16. The PT/OT percent delivered by assistants, obviously you'd like to see that be lower and more being provided by therapists. And then I do really look at the full-time FTEs for nurse practitioner and PA. You want that to be a yes. And the medical director on site more than a week for quality and leadership should be a yes. And then the on-site mental health professional is also very helpful. So this particular slide, is one of our high performers. And you can see they have a high percentage of licensed RN. Their indirect care is okay. It's not quite as high as I'd like to see. The APN coverage for more clinical touches is there to support the SNF physicians. And they do have the medical director for more than 1 day a week, and also the on-site mental health provider. So you can go to the next slide, please. So I also wanted to show you what the staffing would look like for one of our not so well performing skilled nursing units. Here you can see that we have a low percentage of licensed RNs. It's about 11% lower than the state average, and I generally will look at the state average, and I think that's the one that most of the SNFs are interested in looking at. The indirect care is kind of average to low as far as the support of the nursing staff. There's no APN coverage, which means there's less clinical touches. There's also a fairly good PT to OT delivered, high PT to OT delivered by assistants, which we would like to see lower. And the medical director on site more than 1 day per week is not there. They do have an on-site mental health professional. So I think you can see pretty clearly the differences that can be outlined in, and how these SNFs could be expected to perform. And you can go to the next slide, please. So then the next domain is care processes and outcomes. And the components I like to look at there are the percent of patients in pain management programs, the advanced directives, percent of patients with advanced directives. And you can see in this case it's very low. It's 33% below the state. So, that's a red flag to us. Those patients diagnosed with depression, we all know that probably 20 to 35, 40% of patients in SNFs will have depression. So this is about a normal amount. Facility-acquired contractures is really based on the long-term care within the facility that you're looking at, but it's an indication of the robustness of the processes that they have in place to improve mobility. And you can see that this is not a good sign for this institution because they're 4% higher than the state average. And then also respiratory therapy. The percent of patients that are getting respiratory therapy is very low here, and that's an indicator that there's a low percent of, that indicates a lower level of skill and nursing competence. You can go to the next slide, please. And then the last one I wanted to review with you is the quality measures and compliance domain. And you can see that moderate severe pain is about 29%, so it's about 11% higher than the state average. And that would indicate, poor compliance with the pain management program. And then under the compliance rate of post-acute care, you can see that the state survey with 3 citations for patterns of noncompliance, which is high, and the state survey with 2 citations of actual harm and jeopardy. And worst of all, the facility is at risk for special focus review. So, again, there's a great deal of information in all these domains, and this is primarily useful, when you're going to meet with the individual SNFs to talk about their performance and how they have to improve within our particular report card. Next slide, please. So I wanted to give you a look at the PointRight spreadsheet, at least the truncated version that we look at. So as you can see, we have incorporated the CMS star rating in that first column, and then the 5 domains, with all the different patient scores, and by row these are linked to our aggregated figures in the utilization data, and we'll show you that on the next slide. And then again, we didn't use that second to last readmit rate because we actually have the actual readmission rates for. We didn't have to use a predicted value. We use our actual data. Next slide, please. So this is really what our report card looks like at this point, and this is where we've integrated the claims and quality data. And on the left-hand side is the utilization. The right-hand side is the 5 domains. We weighted the utilization at 40, using, again, average length to stay as 10%. You can see that in the light blue row. But we really rated the 90-day readmit rate really 3 times all the other columns because we felt it was really the most important and had a huge impact. So again, a 60-40 split between quality and utilization. And again, felt that rather than use cost, which we have, and we do look at, that using these 2 areas or metrics was a good proxy for cost, and I think it's turned out to be that. Next slide, please. So Donna spoke to the preferred provider list, but I wanted to give you a little bit more data on that because I think it's been a very important tool. And ultimately, we wanted something that we could take out and share with the families and the patients. So we developed a preferred provider list, and it's meant to be taken to the bedside. And it's not only had a profound impact, I think, on the patients and family and the choices they made, but it really, once the SNFs realized, we were going to the bedside, in order to present this to the patients, I think that really helped them get a bit more engaged in the whole process. And they frequently request updates to this list, kind of looking at, well, where do we stand? Did we make a star? And I think that's helped us a lot. They continue to work hard to improve their quality and the utilization in order to make the list. And there was one SNF that really, I think, was so disappointed in their performance, and they were really at the bottom of our report card, that they made some real significant management changes at the facility based on the poor performance due to the performance on the report card. And then the influence on the families and patients, I think, is significant when you see that initially 35% of the patients chose the starred providers, and this has now increased to over 50%. And I think that shift as well has gotten the attention of the SNFs. You can go to the next one, please. So I just want to give you a sense of what the preferred provider lists look like, and you can see the preferred providers at the bottom. We do have it broken out by county, so it's a bit more regional for the patients and family to select. And we do have a disclaimer in the middle there that says those facilities with a star next to their name are preferred providers and top performers based on our quality and performance program. And so I think it's a strong statement, and it's been a valuable tool. Next slide, please, Patra. So I'd like to discuss next integrating the PointRight and SNF scorecard into the management of SNF performance. And we found the scorecard was an invaluable tool for working with the SNFs. And a lot of what we talked about as far as coaching the administrations there, making sure that they're focusing on the things they need to focus on in order to actually improve. So we were addressing staffing with them, leadership management, whether they should add advanced practice nurse coverage, process issues like depression screening and patient mobility. And it was interesting, not to say the least, that most of the time they weren't aware of why they weren't scoring well on the scorecard, and the scorecard made it very, very clear to them where there were areas where they could improve. Next slide. So what Donna and I started to do, we started setting up meetings with SNFs based on their performance on the scorecards. We initially focused on average length of stay and readmit rates. We had set expectations for the staff, the patient, and providers that length of stay should be based on functional status, not a predetermined number of days. So many times we would hear that the folks in the facility would go in and say, you're going to be here for 3 weeks. And we really wanted to change that dialogue to based on what was the goal of the treatment or their therapy. So something to the effect of, you will be discharged when you can climb a small flight of stairs. And I think with the folks that we now have working with us, that dialogue has begun to change. They may want to provide more intense therapy in order to move the patients along faster. Again, an option to add additional nurse practitioner coverage so that those patients get more touches, and then also the development of clinical protocols. Next slide. So and the next set we looked at was readmissions, as I mentioned, and we found that sometimes the providers early on had a very low resistance to sending patients to the emergency department when the treatment really could have been handled in the SNF. And we found that when we did address this with both the physician providers in the SNF and the administration, that there would be some finger pointing between the providers and the administration. And so we found these meetings that we set up, the three-way meetings, that was very helpful in terminating some of that behavior. We also encouraged enhanced coverage with the nurse practitioners so they could begin to recognize disease processes progressing and maybe make an adjustment in the treatment sooner than might happen without a nurse practitioner there. And we needed to change everybody's mental model. And I think once we were able to get the facilities to see the trade-off of volume, they would be losing some days with regard to length of stay shortening and readmissions, but the ones that are participating and working with us in a value-based medicine process, are getting more volume. Go to the next slide, please. And this is just a replay of the slide that Donna showed. And this is, again, where we started with the Medicare Shared Savings Program. And as she mentioned, we had 4 quarters in a row where our costs went up in 2014. And in 1 year, it went up $100. By quarter 4, we were about $286 per member per year over the national average. So that was the beginning of us, beginning this program. So the results, next slide, please. The results of phase 1, which really began at the end of 2015 in the Medicare Shared Savings Program, we had 4 quarters of decreasing costs and an actual reduction in cost over that year of $137 per member per year, which over our 22,000 lives was about a $3 million reduction. So what we saw was a 14% decrease in SNF days and a 13% decrease in costs. And we reduced our MSSP costs by about $6.6 million, and our SNF reduction was just under 50% of that reduction. And so I think you can see that the SNFs are taking action to change their results, including adding staff and relooking at how care is delivered. Next slide. So then we needed to look forward to 2016 and began phase 2. And the SNF report card provided valuable information on best candidates for extensivist program. We wanted to look at the high volume, high cost institutions. We wanted to overlap with our existing ACO physicians and providers that cover the SNFs, since now they had a stake in it. Because they had some significant shared savings, they were more open to helping us manage and reduce utilization. We also made the decision that we wouldn't bill for the services that we're providing to support those physicians, so that we wouldn't interfere with the PCPs. So initially we identified 8 SNFs that also had administrative commitment to a change in culture, and we're in 5 SNFs now and continue to expand those services. Next slide. So the initial goals of the SNF initiative was, with phase 2, was hire a SNF extensivist, which we've done. We hired 2 APNs, And what we're learning is, this is probably one of the most powerful pieces, is the post-acute RN transition nurse who sits on the SNF discharge and planning meetings and really works with them to make sure that when the patients are ready to be discharged, that they do get discharged. So as part of the the projections and savings, we looked at a pilot of 6 facilities, and 1-day length of stay reductions, 2-day length of stay reductions, and 3-day length of stay reductions. Next slide, please. So the results of phase 2. Patrick, you're on the results of phase 2?
That's correct.
Okay. In 2016, 20% reduction in annual per beneficiary costs, PMPY, for the MSSP program. And you can see our historical benchmark was $12,739. And by quarter 3 of 2016, the total cost had come down to $10,124, which is a $2,615 reduction, from our benchmark. So, and even probably more importantly, or just as importantly, is the fact that I think the SNF was a major contribution to the reduction in cost. So we saw a 40% decrease in SNF per member per year in 3 quarters. But if you go back to quarter 4 of 2014, there's a 50% reduction in since quarter 4 of 2014. So you can see that we're also below the national fee-for-service average. So the results have been very, very strong. Next slide, please. So as far as the lessons learned, take time to establish relationships with the SNFs and be as transparent as you possibly can be. Engage them in the goals of the ACO, and they will respond. We have some really good relationships with these folks in these facilities at this point. I think the next point is really important. Learn the operations and business of the SNFs, including understanding how the SNFs are reimbursed. When we sat down and actually went through the comparison of our claims data, to what they were being reimbursed, they were as transparent with us as we were trying to be with them, and took the time to explain to us how their process worked. And it really helped us make some good decisions on how we approached them when we started talking about action plans moving forward. So we didn't overreach. I think it was important that we did not overreach. Don't ignore your role of your ACO PCPs. What we found is that once the shared savings started to come, they became less threatened and much more willing to work with us to reduce costs. An ACO, even a hospital-based ACO, can positively impact SNF costs. And then also strongly consider the post-acute RN transition nurse to work with the SNF and discharge planning process within the institution. And then also, this is not a marathon. This is a marathon, not a sprint. So, hang in there. It is a lot of hard work, but it will pay off. At this point, I'm handing it back to Richard from PointRight to finish up the presentation.
Great. Thank you, Donna, and thank you, Dr. Warden. I'm just going to spend a couple of minutes talking a little bit about a little bit of a reiteration to what Dr. Warden and Donna talked about regarding clinical data and not just claims data. And really what we're trying to get accomplished here today is that, no matter what the type of data that you're using, whether it be both public data, as Dr. Ward mentioned, or any other data source, claims, etc., really having clinical data is a very, very important and key to the success and foundation of a successful post-acute care strategy. So because you need clinical data and because there are certain challenges that are associated with those, I wanted to talk just for a few minutes about some of the things that may be misperceptions around clinical data, and also talk a little bit about some of the technology that we're using to ensure the protection of our clinical data and make sure that that data is in a secure environment. But those that kind of consider the challenges associated with post-acute care data is that post-acute data is being perceived as old, or post-acute care data is affected by patient choice, or post-acute care data is a product of the fee-for-service environment. These are challenges that are continuing to be present within the post-acute care space, and what we're doing here at PointRight is really trying to help individuals overcome those challenges by showing them that there's opportunities to bring together different types of data, whether it be claims data, whether it be public data, whether it be MDS data, in a way that can get people on the same page. We know that there are what we call upstream data problems. So payers or other consumers of post-acute care data don't necessarily understand this data. But they're getting smarter, and there are several vendors that are working within this space, and it's only a matter of time before some of post-acute care becomes, the data associated with post-acute care becomes a standard that is transcending not only the post-acute care environment, but also upstream as well into the acute care environment. And there's also a lack of standardization in data requests that come from hospitals, from ACOs, and payers. And one of the advantages of using a data assessment tool like MDS is that it allows for standardization and data capture, and allows for organizations like ours to apply some of our models that have been endorsed by third parties like the National Quality Forum to that data in order to allow for folks like Lourdes to have a lot of confidence in what they're seeing. And then most importantly, helping you weed through what can be a data overload, and how do you focus on those things and measure what you can manage and what you can change. And I think with the great examples that Dr. Warden showed today around the staffing domain and around the care processes domain, they really said, these are the things that we're going to pay attention to, and these are the things most importantly that we're not going to pay attention to. And those things that we are paying attention to, here's the story that they're telling us, and here are the changes that we're going to make as a result of that story. And I think you can see the results that they had spoke for themselves in terms of their effectiveness. So just a little bit about the minimum data set. We've talked a lot about MDS. And for those of you that maybe aren't intimately familiar with MDS, we like to think of the MDS as sort of the foundation for a post-acute care strategy from a data perspective. And again, it gets more powerful when you can combine claims data and public data, as in this example we saw here today. But the MDS is about 38 pages of a multidisciplinary assessment. It is the standardized clinical assessment that is required by CMS for all Medicare and Medicaid residents within certified skilled nursing facilities, so that data is being collected. It's about 500 different data points in a standardized format that address members' physical, mental, social functions, activities of daily living, diagnoses, symptoms, treatments that they are on. And again, when folks talk about, well, post-acute care data is quote-unquote old, well, the MDS is actually performed quite frequently, required by CMS on days 5, 14, 30, 60, and 90 of a post-acute care stay, and quarterly thereafter, and of course is always required upon readmission or return to SNF for a sort of resumption of care, and at the start or change of any therapy, an MDS is required. So hopefully folks can start to see how there's a lot of information that's there, and obviously PointRight has developed an entire solution offering around this. When we talk a little bit about why it was really important for us to think very tactfully about the technology that was in place here, because we're talking about clinical data, and because we're talking about needing to create highly available and highly scalable applications. We had some key considerations when we were thinking about reliability and having a secure and reliable integration. So we were thinking about things like data security, the resiliency and the privacy of data, how quickly we could innovate and bring new opportunities to market, making sure that there's an ease of access, that we were creating web applications via web application services that were really platform agnostic, that could work on any device, really making it ease. That we could handle big data management. As we mentioned, we're creating scorecards for every skilled nursing facility in America, so over 15,000 skilled nursing facilities, and you saw some of the depth of the information that's available in those skilled nursing facility scorecards. So it requires us to have very durable and very highly available and scalable storage, as well as the ability to bring on additional virtual machines if we need to scale up or scale down. So high availability, high scalability cloud application is what we were striving to build. And for us, Microsoft Azure, checked most of those boxes for us, or no, not most of, all of those boxes for us. And this is just a quick sort of a high-level diagram of how we're implementing some of the application servers, load balancers, ETL servers, and application gateways and traffic managers to make sure that our delivery for these scorecards, so how Lourdes is consuming this information and getting this information into the hands of the folks that they need to, or any of our SNF customers, SNF scorecard customers, are being able to do that in a way that is highly available, scalable, is got the performance that they need. Okay. So this is just a quick little look here about how our product is sort of look and feel. So it is a web portal, software as a service that our clients will log into and be able to create and configure these national or state or county or local comparison groups. As Lourdes mentioned, they built their comparison group. I think there's somewhere up of 140 facilities that are a part of that comparison group. Allows you to search through them, add them, and then generate these scorecards. It's 100% of the recognized CMS providers for post-acute in the U.S., so something in the order of 15,000. It uses our aforementioned National Quality Forum endorsed predictive 30-day rehospitalization grades to help you rank SNFs by performance in specific cohorts. So you saw earlier in the presentation there were A's and B's and C's and D's being associated to performance for things like rehospitalization prevention for some of the key areas that are being focused on as part of the hospital readmission reduction program, so COPD, CVA, heart failure, etc. And really, as was demonstrated with the work that was done by Lourdes, it helps you to sort of grade and compare those providers that you need to examine across state, across regional, national, or any customized grouping that you want to do via this web tool. And just really to kind of bring this together for us, when you take a trusted platform from a scalability standpoint, from a data security standpoint that's highly scalable, and use that to help drive performance, so you kind of combine a trusted platform, combine access to your data, it really helps you to build a successful network. And we here don't necessarily like the term narrow networks because they're sort of focused on efficiency and geared towards one particular stakeholder. We like to think of high-performing smart networks that are customized to fit individual needs, and most importantly, those that are data-driven. And really, just to kind of give a quick summation of the benefits of data-driven PAC networks and what they achieve. We talked a little bit about those clinical cohorts, COPD, CVA, pneumonia, heart failure, etc. So being able to quickly identify those facilities that excel in a particular clinical cohort where maybe their star rating doesn't necessarily align to that. So they may have a low star rating or a 3-star rating, but But if that is the only lens or the only proxy that you're using to keep someone in or out of a network, you may be missing some really great opportunities for some facilities that are particularly well suited to manage particular rehospitalization risk on clinical cohorts. In addition, you can better align your patient's clinical needs with the top performing providers. So looking at special competencies within nursing facilities, as Dr. Warden demonstrated. Ultimately, there's a great opportunity to use this data to drive your pay for performance and pay for quality initiative programs. Of course, the end result of reducing readmissions and readmission penalties. And then again with Lourdes, we saw that they took a care transition program and were able to ensure its success and make it even more successful. So with that, I believe I will hand it back over to Gus to facilitate the rest of our webinar from a question and answer perspective this afternoon.
Yes, thank you, Richard. So our first question, I think it's for either Donna or Dr. Warden. The question is, how do you measure ROI of the scorecard? You did share a lot of good information about savings, reductions in patient cost. But do you have a measure of ROI?
Yeah, this is Todd. Generally, when we're deciding whether we make an investment, for this particular project, since we weren't doing billing, one of the advantages, obviously, of being in a shared savings program is that we can project that if we reduce the length of stay by 1 day, it's going to be X dollars for this number of facilities. So, I mean, that's basically the way that we generate these, obviously then offset by the costs of the development of the program. We're doing the same with community-based palliative care. We don't plan on billing because we don't want to incent any patients not to participate, and we think the upside is so significant that we really spend our time projecting what we think our savings will be.
Very good. Next question. Well, this is for Richard. Does PointRight have medical data from all Medicare SNFs or just from their own clients?
We have a combination of both. So in terms of accessibility to national data sets, we have national data sets that we can get from CMS, from other private data sources. So we do have data that's available on all skilled nursing facilities. But when it comes to some of the predictive work that we can do around tools that we have for predicting rehospitalization, tools that we have around helping with managing high-risk patients, that information is derived from the MDSs that we are collecting on the subset of the national providers that we have as part of customers of PointRight services.
Mm-hmm. I think this is also for you, Richard. Which EMRs do you typically see in the SNFs, and do you know if, and then this other question would be for Lourdes. So let me just leave the first one to Richard.
Sure. So, PointRight, we, like most analytics and business intelligence providers, we need to be EMR agnostic. We need to work with all of the EHRs, especially those that are utilized for the purposes of completing MDSs. So that's a big point of what a lot of EHRs within the LT-PAC setting are used for, not just for the completion of MDSs, but that's a big component of it, along with billing and clinical documentation and vitals and meds and management and other things, order entry. We're working with those that are some of the largest players in the market. I think we're working with the 6 or 7 largest players in the market. So Point Click Care and HealthMedics and American Health Technologies, NTT Data, Matrix Care. I don't want to leave anybody out, but those are the ones that we are working most closely with today.
Okay, and this will have to be the last one, and it's for Donna or Todd. Do you have interfaces connected to the SNFs?
Hi, it's Donna. I can take that one.
Okay.
So the EMR that we see the most is PointClick. We do not have interfaces with post-acute EMRs. We did, however, develop a tool for the skilled nursing facilities to use as an attribution search for our attributed lives.
Thank you. Well, and that brings us to the top of the hour, so we're out of time. I'd like to thank Donna Antonucci, Richard Jupnavorian, and Dr. Todd Warden for their contributions today. It's very informative. And I'd like to thank the audience and let you know that you will be able to get a replay of this session. You'll be receiving an email within a few days. You can share it, review it, and it'll be available until May 7th. Thank you very much, and as you leave, you'll be asked to complete an evaluation of today's session. We appreciate your taking the time to do that. We work to make sure all of our webinars are as valuable as possible. So thanks to the panel and thanks to the audience. We'll have a wonderful day.